So here's, well, these images kind of go through a lot of that, but close reduction, this is one of the examples of a close reduction where they manually manipulate and put the bone back into place. And again, this is done without surgery or hardware. Now, the things you would do for a patient that's had a closed reduction. Number one, elevate the affected extremity as much as possible. That's extremely important. Okay. Sometimes they will reduce the bone, but if they put a cast on too early, the swelling can get to the point where it's, you know, it's gonna have to be removed anyway. But you can help with that. Elevation is extremely important. There were times, and you know, all of our orders elevate the extremity, elevate the extremity, elevate the extremity. Pretty much that's a standard orthopedic order. Okay, unless they don't want you to do that, then they're going to give you that order as well. But we would use it's stockinette stuff that we could kind of create a dressing out of, but it was basically stretchy fabric. They use it on the internal side of cast and things like that. We would take the end of that, tie it to the extremity. You know, if it's a cast or whatever that they've already reduced, or you know, they put a cast on, to help with that elevation, you can actually attach it to maybe an IV pole. You can attach it to something to keep that extremity elevated even greater. That's kind of like skin traction, but it's not completely. But that really helps with the swelling of the fingers. You've got an arm cast, that would really help with that. But either way, as much as you can possibly elevate that extremity, you want to do that without obviously injuring or anything. But all right, you also want to apply ice as ordered for the first 24 to 48 hours. A lot of the physicians we worked with, they would come out of surgery and they would have there's an ice system that they use, EBI systems, and they actually have a wrap that you put onto the extremity, and then it's attached to 2 cords and a cooler. You fill the cooler with ice water, and it cycles that ice water through that pad on the whatever extremity it is, and that significantly helps with swelling, especially those that came out of surgery that had internal fixation, you know, some type of rod placement. You could do that, and it would greatly help with the swelling. All right, you also want to remove any rough edges of the cast. We would use, call it lamb's wool, just really soft fabric that we could use to help with these rough edges, kind of put around the rough edges. You don't want to cause some type of laceration or skin breakdown following the fracture. They put a cast on, and it's, you know, you've got rough edges. You use tape, anything to take that rough edge away from the skin. Okay, those casts can be very sharp if you don't kind of file them down or use something to cover them up. And this is probably right there on the top of the list. Frequently assess neurovascular status. Okay, the 6 P's. It doesn't stop once they put the bone back in place. That doesn't mean you stop assessing the 6 P's. That's from the time they get there to the time they leave. Every time you walk in the room, if you just go in to drop off a cup of ice or whatever, you walk down there. If it's a leg, you know, I'm constantly walking down. I'm assessing fetal pulse. I'm assessing cat refill of the toes. You know, hey, can you wiggle your toes for me? You know, that doesn't have to be a set. You know, yeah, you're going to have orders for every 1, every 2, every 4 hours, your vascular checks. That doesn't mean you can't do it more often. Okay, constantly assess those 6 P's. Right. Next, never disregard complaints of pain. If you've got a patient, and now orthopedic patients they hurt. There's a lot of pain medicine that you have to give for orthopedic patients, but don't disregard that. If you give them pain medicine and it continues to hurt, it could be a compartment syndrome issue. It could be a cast that's too tight, a splint that's too tight. Some other issue may be going on. Don't disregard it. Make sure that you notify the physician, and make sure you document that you have notified that physician. So when they come back and say, hey, my patient's been hurting all night, I looked and there was something going on, maybe the cast was too tight, something like that. Well, I called you at 4 o'clock in the morning, I called you at 4:30, I called you at 6 o'clock. You know, those are documented things, you know. Well, I was asleep and didn't realize it. Not my problem. I've documented it. I called you. All right, next. Check for odor, which might indicate infection. Now, these casts will stink, you know, from the sweat and all the stuff, you know, in the cast. But if you've got a foul odor, they need to open it up and recast. Find out, is there infection down inside that cast? Patients will constantly, they stick stuff down in there to scratch, or they, you know, and that causes greater breakdown, and they have a laceration inside, and, you know, there's a lot of stuff that, you know, they do with these casts. You know, anytime you've got an odor, you need to investigate a little further and see if it's infection. If a cast is too tight, again, you know, it can be cut, it can be split. Now, does anybody know how those cast saws work? Okay, it's frightening, right? Yeah. They're not going to cut the skin. Okay, they're designed to not cut the skin. They use heat and some of this other stuff. So it's almost, well, it's not impossible, but it's pretty difficult to get a cut off of it. So if a patient is, you know, if a patient has a cast to be cut off, you know, kind of, you know, ease them off some of that fear. Explain to them, hey, look, this is a saw that's designed to not cut you. It's designed to not, you know, not break the skin and cause more damage when we cut this off. You know, let them know that ahead of time. Make sure that they are aware of kind of how it works. And it's a special saw. This is not something they pulled out of the garage and they're trying to, you know, carefully cut this off without breaking the skin. Now, so what are, you've got a patient with a closed reduction. They put a cast on. What are some of the nursing diagnoses you're going to have for this patient? Okay, risk for impaired skin integrity, or it may be that they have impaired skin integrity. All right, what else? Yeah, definitely. Could have a disturbed body image. Impaired mobility, that's going to be a big one. Okay, activity intolerance. The muscular atrophy. Okay. Yeah. I don't know if that's, I don't know if that's nursing diagnosis, but yeah, that happens for sure. Anxiety. Yeah. And it may be that they've gone through the entire process, the bone's healed, they're going to take the cast off, and that's when the anxiety occurs, and they're having to get it cut off. Okay. Yeah. Altered activities of daily living, for sure. Yeah. Yeah, that's probably going to be one of your priority ones. Risk for altered tissue perfusion. It's a big one. What else? We've got immobility. What else related to that immobility? Risk for falls, safety. All right, you got a big giant cast that now is, you know, 7 or 8 pounds or 10 pounds added to that extremity. It makes you a little off balance, right? Risk for falls. You know, maybe crutches. You know, they're on crutches now, and that, you know, they're not the most coordinated in the world, and that, you know, it makes it tough. Okay. Pain was another one. I don't know if we mentioned pain or not, but pain, you know, those are all very, very important things, and you'll see that as a common theme. Those nursing diagnoses will follow you through the orthopedic content. Yeah. Risk for constipation. You know, patient's immobile, they're not moving around, or it hurts, or they just don't want to. Constipation can develop as well. And what else are we doing for the patient that could put them at greater risk? The medicines, narcotics, the pain medicines that we give. On the orthopedic floor, you'll commonly see Colace ordered right there along with Lortab or morphine or whatever. I mean, they just about give it hand in hand. But anyway. So these cast, splints, and immobilizers that we use, one, they hold the reduced bone in place. Also, they apply compression to soft tissue. Part of the reason they kind of shrink, and we almost dehydrate that extremity a little bit. Not completely. We're not going to dehydrate them, but it compresses some of those fluids out. Helps prevent early mobilization without increasing the risk for further injury. And it also corrects and prevents deformities. Some of the types, we've got short arm cast, long arm cast, short leg, long leg, spica cast. Anybody know what a spica cast is? It's similar to a body cast. I don't know if I've got a... and these are examples of, well, the ones in the middle. This is a spica. This is a double hip spica. They're used to immobilize whatever they need to immobilize, usually around the hip, the pelvis, kind of in that area. The double hip spica, this right here is a stabilization bar. So they've got a cast on on both bilateral extremities. Then they have a bar to stabilize and keep it in that position. If not, probably likely to break that the cast or whatever. But this helps to stabilize. Now you will see lots of variations of these depending on what the patient needs. We would have patients that they had trouble. Well, okay, I got a patient in this cast or this cast. What do you also have to assess very, very closely? Skin. But think about how high this is. What could that also affect? Breathing and respiratory. Absolutely. It's up high into the chest cavity, right? Or, higher up. The patient, we need that chest expansion and contraction, right? So if we've got it too tight around the chest and it does not allow for full expansion of the chest cavity, then we've got reduced respiratory function, right? No, they don't have to have a Foley. Now, usually they would have a Foley coming out. And I'm also thinking in terms of pediatrics too, a little bit. The pediatrics, you've got to keep the cast dry, correct? You can't have urine and feces and all that going down in the cast. If you do, you've got a lot of infection going on, okay? So, part of the thing, it's kind of like maintain the airway. In orthopedics, it's kind of like maintain the cast, keep it dry, keep it intact, all that kind of stuff. Now, it's not near as important because they can replace a cast, but it's fairly important. You take off an ortho doc if they have to go in and redo a cast. So, we would have to come up with ways to keep it dry, especially in pediatric patients who can't really tell you all the time when they need to go to the restroom. Incontinence. And if you've got the patient laid, on their back, ulceration, big time. But if you've got a patient on their back and we're trying to elevate the lower extremities, okay, what happens if they have a bowel movement? It may not go down, but it may also go up the back part of the cast as well. So there's a lot of things that you have to kind of have in play there. Pediatric patients that maybe they're potty trained, they've been potty trained for several years, they still come in with a diaper. Okay, we would develop. We had mud flaps. I don't know another way to describe it. It's a surgical drape that we would use. You put the drape on the dry side and flip it up so that nothing can get by that barrier. It's basically a surgical barrier. You have to kind of be inventive sometimes on figuring out ways to keep it dry. a urinal, and a bedpan. You know, and look, initially they probably, a lot of times they would come out with a Foley catheter. And constipation is a huge issue with this patient because they're still immobilized and they're still getting all the narcotics, probably more. So constipation is a huge issue. You got to initiate the Colace and the stool softeners and the Miralax and all that stuff pretty quick. There are a lot of patients that will not tolerate it as well. A lot of times, you know, see this little hole here? That's to assess the abdomen. You know, that's what that's used for. So you can go in and at least palpate the abdomen and see what it feels like. We would have to have physicians or orthotechs come in, and they might have to cut all of this part off and have a lot bigger opening because these the abdomen, the constipation sets in and it gets more and more distended. So for us to be able to assess, for them to be able to tolerate it, they would have to alter it and modify those spicates. Now they want to keep it in this, as close to this as they can because of the integrity of the cast. They want to keep it, you know, with the most integrity, but you know, they also have to modify based on the patient's condition. And look, they're not all going to come out with a nice perfect circle like this and in this perfect, you know, there are always going to be different variations that you have to look at. Alright, so those are spica casts. You know, they're not fun to, they're definitely not fun for the patient. They're not fun to take care of all the time either. But the key is make sure you maintain the integrity of the cast as much as you possibly can, and keep it dry. Make sure that they know not to stick stuff down in there to scratch their back or scratch their stomach. No. Those are just general casts. Yeah. The only spica cast is here. Okay. This is a body jacket cast. They have different names. A lot of times we would call this a shelf cast. Well, not necessarily. That's not. Shelf's a little bit different, but the physicians will have a million different things that they like to call it. They like to have their own cast and their own name sometimes, but that's a spica. Okay. All right. The key is assessment of neurovascular status. If you have a spica, what are you going to assess as far as neurovascular status? Everything, every extremity, pretty much. And think in terms of, okay, I've got a long leg cast on the left side. Am I only going to assess the left side? Why would I want to assess the right side? To compare, right? So you're going to assess, you know, you got a patient with anything on the legs, you're going to assess both, you know, neurovascular status on both extremities. With the double hip spica, you got to do that. You've also got to assess, well, you got to assess kind of in the inguinal area. Make sure that there's not too much pressure in there. A lot of times there's pressure on the bladder here, so they can have distended bladders. You know, like you said, it's not real comfortable to use the restroom, you know, either method there. I mean, it's, you know, it's not real convenient. So you've got to assess that constantly. Okay. All right. So those are casts. This is kind of the, you know, the nice hard cast that you see. It starts out looking like this. It's a roll of gauze is what it looks like. A fiberglass cast is made out of fiberglass. When you wet it and roll it out, you know, it gets hard after it dries. We would use plaster cast as well. Usually the plaster cast was on the really small kids, or if they want to really assess for drainage and bleeding underneath the cast. A lot of times you'll see that plaster cast is a little softer than the fiberglass. Again, you don't have to know why they use any of them. As a nurse, you just need to know you're assessing neurovascular status regardless, and you want to maintain that cast integrity as much as possible, and educate the patient on doing the same thing. Okay. Again, this is just kind of a look at the process. You don't have to know all this, but well, now this part of it, you may need to kind of finish up the cast a little bit. If you've got some rough edges, this is what I was talking about earlier with the taping. There's cast tape that they use. There's pink tape that they use that only sticks to the tape. It only sticks to itself. You may have to kind of, be I guess a little bit inventive in the ways that you work on these things a little bit. You may have to shave it down some. Lamb's wool is one of the cloths that we would use, and it helps to it's just a nice soft thing to cover up rough edges with. Oh yeah, sometimes you could walk in the room and say, okay, that was Dr. So-and-so's cast. Oh, that's an awful cast. I know who did that one. It's definitely some are better than others, for sure. And there's some that you never had to cut. There's some positions I never once had to even fool with a cast saw on. They were always the perfect, they were the perfect tightness, I guess. And then some you knew, all right, go ahead and get the cast saw and lay it at the bedside, because we know we're going to have to use it in 3 or 4 hours. I don't know. Oh, so they went ahead and live out, and some will do that. And a lot of times it depends on the injury. Where did the fracture occur? Are they expecting a lot of swelling? If they're expecting a lot of swelling, yeah, they'll go ahead and do it. Now, you'll see modifications of just a general arm cast. Sometimes they'll cut in windows where you can assess pulses. You may have a cast that's covering up the entire hand, so you can't even really check cat refill. They may open up windows in different places to allow you to assess that. It just depends on the type of cast and the type of injury. All right, so some of the strategies for cast care. I know we've talked about a lot of it. You want to clean the cast with a damp cloth and a dry cleanser. You don't want to submerge a cast. You don't want to get it wet. Okay? Avoid putting objects under the cast to scratch. Give instructions for care to the patient going home. Encourage increased fluid intake. Encourage increased protein, iron, minerals, and vitamins. Help with wound healing. Okay. Teach isometric exercises, and call the MD if the cast or immobilizer breaks. They need to have a specific set of notification parameters. If this happens, you need to call. If they get it wet, they need to call. It may be that they don't have to actually see the physician. They just come in and their ortho techs cut off the old cast and put a new one on. Just depends on their protocol. But education is probably one of the most important things related to cast, patient with a cast. Isometric exercises are ways, if you can kind of move the muscles a little bit while it's in the cast. So even a hand grasp, range of motion with even the shoulder. If they've got an arm cast in place, a lot of times the tendency is to keep it completely still, even at the shoulder joint that's open. If the joint's open, they need to be encouraged to use that range of motion in that joint. But yeah, they can still kind of flex those muscles, whether it's in the cast. All right, so when it's time to remove the cast, they'll have an electric cast cutter or spreader. Again, that's usually not the nurse that's having to do that part. Okay, but if cast is going to be cut, then you need to have it at the bedside ready to go. Reassure the patient that the blade works by vibration. Support the limb in the same position it was immobilized. Cleanse the skin gently and blot dry. And emphasize to continue elevation and support with an ACE wrap. Okay. All right, so that's all closed reduction. Now we're going to move into open reduction. Open reduction involves surgical intervention, and internal or external fixation may be used to realign and secure the bone. Internal is usually a more permanent solution. External is some type of temporary fixation while the bone heals. Okay. With internal fixation, usually, and I can't really think of a moment. All right, so ORIF. This is a look at an ORIF procedure. Open reduction, internal fixation. Open reduction means, remember, they had to surgically open them up to put it back in place. Internal fixation means the hardware that they're using is inside the body. So internal fixation. So that fixation is to immobilize once the bone has been realigned. Okay. Now this is a computer-generated image. You can search for ORIF on Google or somewhere like that, and they're not going to be nice and pretty like this where you can see it. But that's a good look at an ORIF. They surgically opened them up, and they're using a plate here to hold that bone in place with screws. Okay. Now, orthopedic physicians have to be very creative at times because one fracture is not the same as the next. There's lots of different injuries and things that have, different bones that have been affected and ways that the fracture has occurred, where they have to go in and kind of be inventive on the type of hardware that's needed to immobilize that bone, keep it in place. In most cases, an internal fixation, the hardware that they use, they don't remove it unless it becomes infected, unless there's an issue that occurs related to that hardware. Okay. Okay. So internal fixation means the hardware that holds the bone in place is inside the body. Okay. External, which I'll go ahead and give you a look at the external. External, it's doing the same thing. It's holding those bones in place, but the hardware is outside of the skin. So they don't have the plate inside. They have basically the bar outside that holds that bone in place. So that's your external fixation. Okay. In this case, they've got hardware inside, but it's pins into the bone, and then it's held in place by the external hardware device. Okay. Another type. This is an open femur fixation with IM nailing. Okay. And in this type of procedure, again, you don't have to know the specifics, but it's kind of good to know what the patient's going through so that you can treat them a little bit. Prior to the fracture, so here's a look at the femur fracture. Prior to the fracture, they have the patient in traction. A lot of times, well, it's to hold it, it's to prevent further damage to the bone and the soft tissues, but also it's for comfort. Once they pull that bone back apart, where it's not all compacted and out of whack, they pull it apart so that it provides comfort for the patient, and it also prevents neurovascular deterioration or anything like that or compromise. Now, once they go in for the IM nailing, the incision is here or around the hip, and then they go in with this IM nail, the rod. Okay, so they go in with the rod, and they insert it into the actual bone itself, so it fills in the gaps. Okay, so the bone, the rod goes through the femoral bone. Okay, and then proximal screws are inserted, and incision is closed up here. So the incision or the screws are going to go in and hold that rod, the IM nail, in place. Okay, but it's inside, intramedullary, so it's inside the bone itself. Okay, that's just a good look at one of those. That's a common procedure now for femur fractures. That's usually what they'll go in and do. Okay, it shouldn't really affect it. I don't know that I've ever heard them say, you know, if there's a problem with the bone itself, then you may have some of that. Yeah. Because it's intramedullary. But anyway, so that's just kind of a look. Again, you don't have to know the steps for the IM nail, but that is a common procedure that you'll see. And this is kind of a good look at our a type of the skeletal traction. This skeletal traction is not going through the femur itself. It's designed to basically pull the bone back apart from where they've been compressed. Does that make sense? Okay. Absolutely. Anytime they have to insert skeletal pins, I mean, we've introduced something else foreign to the body. Now, they're at less risk if it's done in more of a controlled surgical, you know, sterile type setting. But we've still introduced something to the body, you know, into the bone there. So that's definitely. Yeah, it can. They would have to go in and replace it. Usually, the bone is usually fairly good about not rejecting. I don't know that I ever had one that just outright rejected a hardware replacement. At least not in the first few days post-op. Sometimes they'll have to go in and replace the hardware. You know, and that it may be that the bone just doesn't grow, or the bone, you know, the hardware is causing more damage or whatever. But usually it's not a outright rejection. It could. Then they would have to go in and do external fixation usually. Well, yeah, osteomyelitis and just general infection. I mean, it may not even necessarily be osteomyelitis, but just infection in general. Yeah, you're at greater risk. Now, not quite as great a risk as, you know, if somebody had an open fracture, you know, just in the general environment, you're going to get, you know, more likely to have infection occur that way. But it can occur anytime we introduce, you know, any surgical procedure that we do. The risk for infection is there. Okay, so this is external fixation. There's another look at external fixation. Now, external fixation, it's not permanent, obviously. We're going to take the rod off at some point. It holds an alignment for the bone to regrow. But it's more, I guess it's more permanent than just like just general traction. Does that make sense? I mean, this is not a permanent fix, but it's more of a long-term fix than just, you know, hey, we put it back in place and put it in general skeletal traction. We've actually aligned the bone now and repaired in some way. All right. So now the different types of tractions that we'll look at. And we're going to see slides of each of these, so you'll see these. But the different types of skin traction, you've got Buck's traction, Russell's traction, head halter traction, pelvic traction, and balance suspension. So first, let's look at Buck's. Well, no, not first. Well, just in general. Here's skin traction in general. It's traction that's applied by the use of elastic bandages or adhesive dressings. Okay. The key here, nothing is actually inserted into the skin, okay, or bone, or I guess more specifically. Skin traction, it's things that are done on the outside that cause the extremity to be pulled in a certain direction, okay. It's not secured by hardware. Alright, so, A here, this is Buck's traction. This is commonly done for femur fractures, where they're basically pulling the extremity really for comfort more than anything. It's not skeletal. It's not anything really that overly invasive. Usually the patients go into Buck's traction and they immediately feel relief from some of the pain. It helps to realign the bone not perfectly, but at least realigns the bone somewhat and takes off some of that pressure. All right, B is Russell's traction. Again, it's another variation. You don't necessarily have to know why each of these are used, but commonly this will be another type of traction for femoral fractures, things like that. It just helps to realign the bone temporarily. All right, C, we've got head halter traction. One of the, it's not completely, there's different variations that they'll do for each of these. We had patients that would come in and, they were coming in maybe for spinal fusions, and the degree of angle of their curvature of their spine was too great to really go in without some type of manipulation. So they would come in and they would usually try the skin traction. It didn't always work. They'd have to go back in and do skeletal, but this would help to promote that realignment. It helps with back compression. If you've got a compressed disc or things like that, they may even prescribe this, in the home, where they would help to not realign, but help to relieve some of that compression on the vertebrae. And then D is pelvic traction. Patients had a pelvic fracture, and they put them in pelvic traction to promote realignment, but also for pain control until they can get in and fix it. Now, with skin traction, and this goes for all traction, you never want to remove traction unless you have an order for it. Okay. Commonly, especially with skin traction, they may give the patient bathroom privileges. They may give them, depending on the problem, depending on how stable the fracture is, they may give them different privileges to get out of the bed, or maybe even sit up in the bed. Our patients that were in the head halter traction to help try to promote, reshaping of the spine, where they're trying to reduce that degree of curvature. They would have different, maybe sit up to the bed, 2 hours each day, something like, or sit up with a chair. They'd have different activities. We even had wheelchairs that had the traction attachments, so you could put them in traction, leave them in traction, and put them in a wheelchair. They still have the whole head halter traction mechanism in place, but they're able to get out of the room. So, again, you've got to have an order for that to manipulate these traction devices in any way. Now, if you've got an order, you can go in. They may say add 10 degrees to the traction, or 10 pounds to the traction. You go in, just add weights to it. They may have specific orders. The key is you've got to have an order to manipulate it all. Okay. You would need an order. Yeah. NCLEX and HESI purposes, you need an order for manipulation of any traction. All right. Now, another thing is you always need the weights to be hanging freely. Okay. So if the weights aren't hanging freely, what traction is going on there? There's nothing, right? There's no traction at all. If the weights are hanging on the ground, not hanging at all, but they're just on the ground, that patient's not in traction anymore. So you have an order to put the patient in traction, right? So make sure that the weights are hanging freely, or ensure that the patient is in a position where they are hanging freely. Does that make sense? Make sure that they don't touch the ground. Now, you can move them up. You can move them up a bit. You just got to be real careful. And I'm trying to think how, because you can't take away the traction without an order. But you can ensure that the patient is in the traction that's ordered. Does that make sense? Now, I want you to look at this. All right. This is traction as well. This is Buck's traction, sort of. All right, I want you to look at that and tell me, is there anything about that could be a potential issue? Yeah. All right. So, and it's close. It's fine right now. But if this moves over, that foot moves over 2 inches toward that bed, and it's touching the bed, or is that patient in traction? Somewhat, but not perfect traction. You want to make sure that that extremity is not being impeded. You know, that there's nothing that's helping that extremity hold the weight. Okay, so if the patient slides down and that foot is touching the bed, they are not hanging freely in traction at that point. Does that make sense? You would want to move them up to where they've got a little more room, and the weights are ensured that they're going to be hanging free. That's a little bit different. I don't. That's basically pulling straight out, so it's not. Yeah. A lot of times there will be different alterations that they put them in based off of the type of fracture. You know, that's still traction though, because the weights are pulling that extremity in one direction or another. It may or may not be what they want it to be. Does that make sense? That may be not exactly what the physician wanted to have ordered, but. All right, then you've got a suspension traction. I've never really seen them use this a whole lot. It promotes alignment, and it provides a footrest basically for that foot, I guess. It's going to help prevent foot drop. But it is in traction. It's in perfect traction, but it's balanced traction. I don't know. I never really saw them use it a whole lot, but that's a lot more complicated to get them in than just a basic bucks or even skeletal. That's balanced suspension. You see, basically this foot is resting up against the block. But they're not having to necessarily hold, the patient's not having to hold that leg in that position. The weights are doing that for them. But anyway, so that's balanced. I don't know if it was because the physicians didn't want that, that type of traction, or if it was just the orthotechs didn't want to put them in that type of traction. But anyway. All right, so what are we going to do for a patient in traction? There we go. In skin traction. Well, provide care to the exposed skin with padding and dressings. I guess before all of that, what do you need to do? Neurovascular assessments, okay? So continue all that. Okay. Oh, absolutely. Well, there's not a lot you can do to, you're going to elevate. If the extremity's elevated and it's turning blue and getting worse like that, yeah, you call the physician. Because there's not a whole lot else you can do at that point. Because they're going to have to find, if you have an order that you could loosen a splint or a mobilizer, then yeah, you could do that. But if it's just if you've got a patient in traction, and skin traction is commonly going to be like that. You can loosen an ACE wrap and see if it helps, sure. But if you just got a extremity that's turning blue, or it's compromised neurovascularly, you got to get on the phone with the physician. All right, number 2, make sure that the heels aren't touching the bed in pelvic or buccal traction. Never remove from traction without an order. And then finally, treat pain and provide comfort measures while maintaining correct alignment. All right, so next we've got skeletal traction. Skeletal traction is a traction that's applied mechanically to the bone with hardware, such as pins, wires, or tongs. And this is kind of, obviously it's an invasive procedure to place a patient in skin traction or skeletal traction, but they can place the pins in a non-OR type setting. It's going to be a sterile technique, but they can do that down in the ER to get them ready for skeletal traction, maybe on the floor or wherever they're going. they're not actually going in and opening up and doing the entire procedure and preparing the bone and placing the plates and hardwares and all that. It's just a quick, hey, we're going to put them in traction, let's place some skeletal pins. Okay. This is a very interesting version of skeletal traction. This is a patient that's got external fixators that are in place, and they've got skeletal traction hanging from those external fixators. So this patient is going to be probably not your most common skeletal traction patient. Usually your skeletal traction is something, like I said, in the ER they place pins. When they get to the floor, the skeletal traction is used to stabilize until they can get them to the OR and fix it permanently. Okay. All right, so that's skeletal. Another version, and this is using skeletal traction here, but also, well, yeah, it's not using skin because it's the traction is occurring from the pins and the halo. So this is halo traction. Yeah, this is going to be cervical, some kind of cervical fracture. They need to stabilize the cervical spine. They'll use halo traction for a lot of other things too. And for our patients that needed to have the curvature corrected or at least improved before they went in and did a spinal fusion, they would place a halo sometimes, and instead of using the head halter traction, they would use actual skeletal traction to hang the weight from, instead of going in and because if the head halter traction, the skin traction is not near as effective as skeletal traction. The skeletal traction is not going to move. You know, those devices that they're hanging from are not going to move and manipulate in any way, unless there's a major issue. You don't want pins to move. So, patient with skeletal traction. Really all the stuff we talked about before with traction. You want to make sure that the weights are hanging freely. You want to make sure that the extremity is not touching something that is impeding that traction from occurring. You obviously are going to continue to assess neurovascular status. But now you've added in pins and pin sides or some other type of hardware. So at the side of that hardware, you have to constantly assess for infection, assess for drainage. You know, there's commonly going to be drainage from those sides. I mean, that's not uncommon at all. But you want to look at the nature of the drainage. You want to assess and see if it's infectious type drainage. If it's clear, bloody, you know, in small amounts, that's not a problem. Usually 24 to 48 hours, it should be easing up pretty good. But if you've got yellowish drainage, even at the 24 to 48 hours, inside that range, and you have yellowish drainage or drainage that smells or anything like that, there's got infection. All right. Now, pin site care. Pin site care depends on the physician, and you have to kind of learn the physicians and follow their orders, right? We had a group of physicians that, in their opinion, they didn't want to have pin site care done at all. They just had us, basically, the way he described it, crust over, and that provided the barrier that he wanted. He didn't want us to remove the scabbing or anything that occurred on the pin sites. He didn't want us to use saline. He didn't want us to use peroxide or anything like that. He wanted us to just basically let it go. I didn't really see a whole lot more infection in those patients than I did anybody else. So, and that kind of went with their external fixators and their skeletal traction. Most commonly, you're going to see peroxide and sterile water used. We would use high-strength peroxide and sterile water. So, and then also the antibiotic ointment. So we would do the pin site care, high-strength peroxide, mix half peroxide, half water, and then, clean, kind of like trachs, a little bit different. The Q-tips, you take those and you clean around the pin sites, remove the little crusty areas that come off and all that, and then provide an antibiotic ointment. There's going to be different protocols for different facilities. Just know you're going to follow the physician's order regarding pin site care. Okay. If you get a patient that comes back with skeletal traction or an external fixator, and it's a physician that commonly or usually orders pin site care and they don't order it, you need to call and get an order. Say, hey, look, hey, just wanted to make sure that you didn't want us to do any pin site care. All right. So next thing, check traction to make the direction of the pull. That doesn't make sense at all. Make sure that the direction is in proper alignment with the way they want it to be. Basically, I don't know. That's even worse. But make sure it's properly aligned the way in the angle that they want it to be in. Does that make sense? Okay. Make sure it's in the right direction. With the long axis of the bone. So if it's a femoral fracture, you want to make sure that the femur is in proper alignment. Okay. Make sure that the ropes are unobstructed. Make sure there's no kinks or knots that have kind of developed or anything that's going to impede that traction from pulling like the way it should. Make sure the weights are hanging freely. And never remove weights without the specific orders from the physician. And don't add extra weights, okay, unless you have an order to do so. All right, fracture activity. This is kind of like an interactive activity, so y'all have to be interactive. I know you love that. But what are some things that the nurse should be most concerned about regarding a patient with a fracture? So what are the things that you as a nurse are going to be most observant for? What are you going to look for? Okay. So compartment syndrome and neurovascular status. All right. Good. What else? Any others? I know there's others. You just got to tell me. All right. Level of consciousness. Yeah, you want to make sure that the patient's that doesn't change for sure. Because why? Okay. And you kind of laughed when you said that, but that's a really good answer. Fat embolism. All right. Well, okay. You both get credit. Fat embolism. Okay. All right. Next. What else? Okay. 6 P's. Infection. Yeah. You're always looking for signs of infection. What else? I got a fracture patient. One of them I want to make sure I check. All right. Airway, breathing, circulation. Yeah. Sure. Okay. Neurovascular. Pain. There it is. Pain. Are they hurting? Well, okay. All right. You're right. Pain is on there. All right. You're right. I took it. I separated it. I know. All right. But you want to make sure you get a good pain score. Okay. Provide pain medicine as ordered, and then also you want to assess for complications. You want to assess for the, did it work? All that good stuff. All right. So how does a fracture impact immobility or mobility? Okay. It's gonna, if you have a fracture, you're probably not gonna be able to use that extremity as well. Okay. It depends. You're right. It depends on the location. It depends on. It also depends on the physician's order. They may be able to use it a little more than they're allowed to use it. I don't like that one. Okay. What complications would a fracture cause? I think there's a missing. I think I left out a case study description or something. But anyway. All right, what complications could a fracture cause? Fat embolism. All right. Huh? DVTs? Sure, because we're immobile. Okay. Hematoma. Constipation. Disturbed body image. PE. Yeah, pulmonary embolism. Yeah. Definitely. Yeah, that's a complication. You're absolutely correct. And if you're not doing your job as a nurse, you could definitely, you know. I mean, and there are patients that, if the degree of damage is to a certain extent, I mean, had a patient fall in the 2011 tornadoes. He had, I don't know if it was a refrigerator or a dresser of some kind, fell on both of his legs. And he lost both of them. Because the degree of damage to the bone was just, he came in and they were almost black when he got there. And there wasn't a whole lot of circulation to them. We kind of nursed them for a week or two, and then it was the necrosis was moving. And once that necrotic tissue starts to move, they don't want to have any more good tissue damage. So he was better off getting the prosthesis. Prosthesis? I don't know. What's the plural prosthesis? Prosthesi? Prosthetics. There you go. So he got bilateral prosthetics on his legs. Whatever. Yeah, that works. Works for me. He got 2 legs on his bilateral stumps. All right. What does this type of fracture, or how about this? How does an open fracture impact the healing process? Okay. All right. It's more lengthy. There's a greater risk for infection. Any others? Yes. The surgical procedure itself is more in depth and invasive. So yeah, that could definitely. All right, and if you have an open fracture and they have to use hardware, hey, look, I mean, the hardware, there's, like you said, there's a risk for rejection. There's a risk for further complications and infection related to that hardware. All right. What medical surgical treatment should the nurse expect to occur? Okay. Ross. All right. Initially, so let's say in the emergent outpatient, somebody falls on the field. Okay. So we're going to immobilize initially where they lie. Okay. Yeah, and once they get to the hospital, we'll get a tetanus shot. What else? Traction. If it's depending on the severity, but yeah, definitely. I mean, they may have to have some kind of traction until they can go in. If it's an open fracture, until they can go in and permanently fixate or whatever. Okay. Pain medicine. Yeah, it may be if the patient has vertebral fracture, sure. Pain medicines. All right. Any other medical surgical treatment that might occur? I've kind of been paying attention, haven't you? So, okay. The need for assistive devices, absolutely. If it's a leg or some type of injury that impairs their ability to walk, then yeah, we're definitely going to have something, some type of crutch or something. And that's going to bring their own education, right? So patient teaching. Good. All right, so that's. See, okay, so here's what happened. Here's the case study. Apparently, those got switched there. So yeah, all right. So I've got a 20-year-old was admitted with fractures of the right tibia and fibula after a fall. Okay. She has a long leg cast that was applied this morning. The physician has ordered bed rest for now until the condition stabilizes. So yeah, you answered all those correctly. Good. All right. Let's see if there's any more. All right. So now our 20-year-old patient has had the fracture. Okay. Later that evening, as the nurse performs an assessment, the patient states that the cast seems too tight. It was difficult but not impossible for the nurse to insert one finger between the top of the cast and the patient's skin. All right. So now, is this a concern? All right. So we've got a patient that says it's too tight. It's difficult to get a finger in, but it's not impossible. So there's discomfort. What are my abnormal things? I've got discomfort. I've got patient report that it's too tight. Okay. And it is difficult to get a finger into the top of the cast. One easy finger. All right, so the correct answer, yes, it is. This is something we want to kind of investigate a little further. All right, a finger should be able to be inserted between the cast and the skin. Ice may be applied for the first 24 to 36 hours to reduce swelling and inflammation. Now, one of the things I would like to see here is a neurovascular assessment, right? So yeah, the cast is a little bit tight, but what does the neurovascular status look like? Okay, and this was what do we got going on? This is a leg cast. Okay, so what are we wanting to check from a neurovascular standpoint? Cap refill, pulses, tingling. Okay, we want sensation, movement, color, all that good stuff. Yeah, 6 P's. So what could I do as a nurse at this point? Elevate. There you go. So at this point, I'm going to elevate. If it's difficult to get the finger in the cast, you may elevate and see if that helps. If the neurovascular status is appropriate, if the neurovascular status is okay, see if this helps. Okay. But then we'll see from there. All right. So now, I'd give it probably 30 minutes to an hour. Okay. If in 30 minutes to an hour, if the swelling has not subsided, or if the swelling has continued, then you're going to call it that point, regardless. Okay. Whatever. At this point, the physician thinks, "Hey, we've reduced, we've put it back in place, and that now we're just kind of monitoring." Usually they leave the toes open in most cases. If not, what they'll do is they'll leave a window. Well, the pulses, sometimes it's hard to check a pulse. It depends on where it is. A lot of times they will leave a window open, depending on where the actual fracture is. But they may leave it open, they may not. If they don't have it open, if there's no way to check the pulse, you can't do it. Now, commonly you could go ahead and check for moral pulses. At least see that, hey, it's good above. We don't have a lot of swelling above. But, you can't check it if if it's not open. All right, so at this point, though, neurovascularly, we're okay. So we're going to elevate and see if that helps relieve because, they'll cut the cast when they need to, but if at all possible, we want to reduce the swelling without cutting the cast because that interrupts the integrity of the cast. It's not quite as effective. But, obviously, if it's cutting off circulation, we're going to. All right, so now we have, I don't know if this is on there or not. All right, so now 2 hours later, the swelling has continued. All right, the elevation didn't work. We'll say an hour later. All right, it continued to swell. It didn't go down, and now the cast is even tighter. So we call the physician. All right, the physician orders for the cast saw to be placed, or physician just says, "Hey, we're going to bivalve the cast." All right. So what are you going to do as the nurse? Get the stuff ready. All right. I don't know for sure. We were never allowed to actually do the cutting. I don't know. In different ortho clinics, they may have nurses where they can do that. That's going to be special training that you would have to have. Okay. At the very least, you're going to get it set up. You're going to get the materials ready to go. All right. Now, once the patient sees the saw, you take the saw to the bedside, and she starts freaking out. Okay. She's scared. What are you going to do to help with this fear? Show her that it doesn't cut skin. A lot of times I'd actually take that saw and I'd put it on the back of my hand, and I'd show it doesn't. Hey, look, it's not cutting. See, look, and that usually helps, especially with kids a lot. You just show them, hey, this is not a saw that's going to cut you. It's not your normal saw. And and sometimes it'll get real warm, so you kind of need to tell them, hey, look, it may get a little warm, because if they're not expecting it, they can really freak out. All right. So now, a few days later, the patient is allowed to get out of the bed with crutches. Crutches have been delivered, but the physical therapist has not yet been in to see the patient. The patient states, I can't wait any longer. Let me try walking with those crutches. I'm sure I can do it because I've played with my brother's crutches before. What's your response? Crutch teaching is very, very important, and it must be done before they can, touch the crutches. Because if not, that the whole liability thing comes into play, and you don't want to be on the other side of that if they fall. Oh yeah, you can teach them. Depends on what the physician's order though. If the physician just orders crutch training, then you can show them. But if they order it specifically from the physical therapist, then that's on the physical therapist. You've got to wait on them. So it depends on how it's ordered. But the key is you can't let the patient walk on the crutches or allow. Sometimes they'll do things when you don't look, but you have to physically or verbally tell them, hey, you can't walk on these crutches until you've been taught how to use them. We were not allowed to take crutches into the room, and the physical therapist is the one that did our crutch training. But the physical therapist, the crutches didn't make it to the room until the physical therapist had taught them how to use them. So as a nurse, if you're going to do the crutch training, don't let those crutches reach the room until they've had that education. Just from a liability standpoint. All right. Also, they need to be fit properly as well. If they're not in the right, at the right height, you could have breakdown under the arms. Safety issues, obviously, they can fall, all that good stuff. And just because they've walked on them with, when they're nice and healthy and well, there's a big difference when you've got a 10-pound cast on your leg. There's a big difference when you've had a change in that mobility and balance and all that good stuff too. All right. Let's see. So now the patient's been discharged and has received instructions for cast care. 1 week later, she calls the office and asks, "Can I get a new cast? This one smells moldy or musty, and it's getting uncomfortable." What is your response? Yeah. It may be that it's just a lot of sweat, and if they call and say, hey, it's getting bad, it smells awful, they need to come in so that it can be inspected and make sure there's not infection. Okay? If it's bad enough, they're going to call in and say, hey, it smells awful, can I get a new one? It's the nature. It's the nature of the odor. Yeah. It's usually pretty obvious. Yeah. Well, and you're probably not going to be the one that makes that call anyway. So the physician will look at it, and it may be close enough, especially if it's gotten to that point. Now, look, if this is a week out and it's already smelling that bad, well, we got some problems. Maybe some hygiene issues. I don't know, but we got some problems. You're right. But regardless, the physician or practitioner is going to need to look at it. All right. Okay. So that's fractures.